friends, sorry for a couple of minutes delay, and welcome to the 45th edition of the PG Track program. And we are deep diving into the imaging symposia, and which is being conducted by Dr. Johan Christopher. And the first session that we had was on magnetic resonance imaging in cardiology, in which we could see a post period of different cases. We knew what are the basics, and today we are going to continue the discussion with a focus on cardiac CT scan, which forms an integral part of the evaluation system. So without wasting time, I would invite straight away Dr. Johan to start his session and educate us, teach us about the nuances and the current norms and current teachings about the cardiac CT scan in cardiovascular diseases. Over to you, Dr. Johan. Welcome from the PG Track Delhi CSI.
Thank you, Dr. Mohit. Thank you for the opportunity again. Apologize for the delay. Just a lot of patience today, so apologize for that. We'll be focusing on CT today as we focused on MR yesterday. A little disclaimer that we'll be showing you a couple of cases. They may not be as per the practice that some of you are already used to, but I'm just showing them just to emphasize the point of using this imaging modality. So just again to recapitulate, the cardiac evaluation unit consists of the thallium scan, which we'll be talking about next week, the cardiac MRI, which we've already talked about, and today we'll be talking about the cardiac CT. How we use all the three together, either in isolation or together, is where the best benefit comes to the patient. Obviously, we are all used to screening populations, and the real area in which cardiac CT really works well and is in its prime time is those who are in the intermediate risk group, which is about 40% of the population. Not much benefit of imaging in low risk, and certainly not in high risk, where patients have to be treated immediately and generally go to the cath lab directly. We also know this data from Falk et al. That most of the MIs, almost 70%, come from lesions which are less than 50%, and that is fairly well entrenched in our minds right now. And also, many of the patients who come with the first vascular episode have not had any prior history whatsoever. Whether you are a man or a woman, the first vascular history sometimes comes unattended. The third important concept is that we know that a normal angiogram, a normal coronary angiogram, does not confer any kind of protection, because as we know, we have some very good intravascular tools like the IVUS and OCT, clearly showing that although the vessel may look apparently normal on the angiogram, on one aspect that there is hardly any plaque, and just downstream, when there you think is a mild narrowing, there's a significant atherosclerotic plaque which is present. So normal angiograms do not mean that your coronaries are normal. And this is just an extreme example of a coronary CT with some of our overlay software which is used, showing the multitude of partially calcified plaques. White is calcium, yellow is lipid, which is same as the black. The pink is the lumen. And you can see that in a single vessel, in a single segment, you have plaques of all different morphology. So coronary artery disease, as we realize, is complex. It's complex in terms of stenosis assessment. It's complex in terms of plaque assessment. And obviously, we do not know the entire realm of this very vastly difficult disease. And this, of course, is an example of a lipid-rich plaque with a thin thin fibrous cap in a vessel, which would have had just a mild abnormality on the angiogram. But here is the deathly yellow lipid core sitting there waiting for it to rupture. If you look at the data from the United States, and this is data which was way back when I was doing my training, the light blue bars indicate the current practice of the various imaging modalities, and this is way back in 2006 when I did my fellowship. And at that time, the paper, when it was published, looked at the possible future expansion of the technology, and you can see that there is a decrement in most of the technologies except a huge increment in the use of coronary CT. In fact, this is one technology that has just exploded onto the scene over the last decade or so, primarily because of its ease of use and its rapid integration with the common cold CT labs. And also it came with a huge property of evaluation of the plaque morphology. So in the pyramid of disease, we do have a large number of imaging modalities to diagnose patients who are symptomatic, whether it is a treadmill, whether it is a dobutamine, whether it's a nuclear or it's the cath. But it is in the asymptomatic and those who are high risk that is truly the place where cardiac CT revels and is able to look at the wall, which we now know is the seat of the disease, is the origin of the disease. And by some very good pharmacological therapy, which we now possess, we're able to reverse some of these patients from high risk to low risk. Cardiac CT also has, and we also know that 50% of our patients in various series, their first symptom is a vascular event, which leads to death. So it is very important that we have a very good screening tool. The cardiac CT obviously can be used in conjunction with some of the other modalities, even in a symptomatic patient or an overt patient wherein the exclusion or inclusion of disease is extremely important. So among the various things, the most important things I wanted to list out for the cardiac CT is to be able to view the coronary arteries, which I think is a very, very important function because the echo can't do it, the nuclear scans can't do it, the MRI can't do it. And for us as cardiologists, to be able to see the coronary is a huge step up and advancement in the evaluation of our patients. The second thing is to analyze the vessel in its entirety. The third thing is the stenosis quantification. We know that most of us believe in eyeballing, even in the cath lab, even in those labs which have the quantification tools. Most of the cases are seen on an eyeball to eyeball level. And it's only now that the intravascular tools like OCT and IVIS are sort of coming in. So CT gives a fairly good, robust quantification, which is inbuilt into the software. The fourth important thing is the plaque assessment. And we have data from Dr. Jagat Narula et al. That apart from the stenosis, apart from the various other clinical tools that we have, what is clearly an important thing going forward is the plaque morphology. Because we have reached more or less a dead end in terms of stenosis. We are reaching quite far with our fractional flow reserve, but still there is a small segment of patients that we completely miss, maybe in the 0.75 to 0.85 range in the FFR, where we really don't know what to do. And the plaque morphology, the plaque analysis seems to be a very important tool for the future. We're able to look through stents, and that is a huge advancement. We're able to look at bypass grafts, and to just quote a very simple example, if you have a doubt with a patient in your outpatient, he's a post-CABG patient with some atypical pain, you send for a CT, 10 minutes later, you have the whole graft pictures and the report ready. This patient needs to be admitted and going to the cath lab and getting all those graft details. And most of our patients don't even come with the graft report. So it's quite a nightmare. Takes a lot of time and energy to do it. So CT has really simplified, especially this aspect. Last but not least, CT can also do a fair function assessment, not as good as echo or MR, but you get a fair LV RV volumetry and an LV RV function. And one more aspect which is obviously evolving is perfusion and scar. And I will just show you one or two examples wherein we are reaching the kind of levels that MRI is able to do at present. It is obviously still reserved to a few labs across the world, but it is a segment in movement and it is an evolving field. And I think sooner or later, I certainly believe the cardiac CT, I'm not going to call it the coronary CT, but the cardiac CT will be a complete one-stop shop for cardiac imaging. Just running through some basics for many of us who have not either used or do not do cardiac CTs. The whole basis of the cardiac CT is based on the gating, the ECG gating, systole and diastole, and that's how basically we divide the segments, and we are able to produce some very, very good pictures. Now, there has been some technological breakthroughs about 2 decades ago, and recently maybe less than a decade ago, by which the average CT scan is now able to look at and report a coronary picture. We all have been using CTs in the past for the brain, for the abdomen, for the lung. I, for one, even during my cardiology training, have never used a cardiac CT. But the important technological breakthroughs have been as follows. A high temporal resolution is required for the CT to minimize the motion artifacts which come with motion. And what came in was an extremely fast gantry rotation. The average gantry makes a full rotation in about a third of a second. And if you look at the gantry size, you can as well imagine it to be an aircraft engine. It's huge, weighing a couple of tons. The second major issue was the high spatial resolution that is required to look at the coronaries. And that became possible by using thin collimators. The third major issue was a fast continuous coverage of the whole thorax, especially in a large adult, which is almost about 14 to 16 centimeters. And the objective was to cover that whole heart in one breath hold, which was not possible before. But the multi-slice CT has made that possible, especially the multi-slice CTs of 128 and beyond. The last thing, as we've been talking about, cardiology basically means something that is tuned to the heartbeat. And the previous generation CT scans could not do that. And to do this, very special ECG gating techniques have come in, using what is called as slip rings, so that they're able to time the image acquisition as per the systole and diastole. So these are some of the fundamental problems that were there, and they got resolved by the engineering solutions that sort of made their way over the last 10 years. These are some pictures to demonstrate what I've been talking about. If you look at the swan on the left, you can see the blurry image. And if you take a picture today with some of our high-end cameras or phones, you can see the beautiful resolution, temporal resolution of the swan as it sort of takes off from the water. The same can be seen in the heart, whereas if you use a low-end scanner of 64 or below, you see a fuzzy image when the heart rate is high. And the same heart appears absolutely crystal clear when you do a cardiac CT with a high temporal resolution. So as I said, there has been a quantum jump in the technology. We're able to do high heart rate imaging. We're able to do even variable heart rate imaging. We're able to see through calcium to an extent. We're able to look at stents, thin collaterals in congenital heart disease, and looking at the lumen in difficult to image plaques. So there has been a revolution, and we have been essentially working at the 16 slice level. But over the last 2 decades, there has just been a quantum jump in the slice number. And we are somewhere between 64 and 128 now. But there are a good number of labs in this country who operate between 256 and 320. Now, a special mention for dual source and dual energy CT. Just to tell you, while the slice number have been increasing in the Japanese models, especially Toshiba, Canon, and also uh, the G and Philips, what the Germans have been doing is to keep the slices intact at 64 and increase the number of sources. So here you see there is more than one energy source with two detector arrays. And this is what is called a dual source scanner. And this is how it looks like, as I told you, like an aircraft engine. Now, what is the advantage of this? Now, this is an example of a single source CT. And you can clearly see there is one source and one detector. It makes a half a revolution and acquires data during that half. So in one revolution, in just 50% of the revolution, that is 0.33 by 2, giving it a temporal resolution of 165 milliseconds. And this is the data it gets you due to the iterative technology. At a low heartbeat, this single source is adequate and gives you very good pristine images. We know in real life that our patients have a high sympathetic tone. The India Heart Study clearly showed that sympathetic tone is a very important risk factor, and our patients have high heart rates. And this is exactly what a patient with a high heart rate looks like with a single source scanner. There's a lot of blurry images. And mind you, most of the labs in the country are manned by radiologists who are not very conversant with using high doses of beta blockers, especially IV. So this is the kind of pictures a lot of us get, and that makes us suspect the technology by itself. Now, this is an image of a dual source scanner. And here you can see in lilac and green, there are two sources, and in orange and green, there are two detectors. So in a 1/2 revolution, as you can see, it's picked up the entire data, and therefore the rotation time is divided by a quarter, which makes the temporal resolution very good at about 83 milliseconds. Our cath labs work at about 55 to 60 milliseconds just for comparison. So at 60 beats per minute, no problem. But when it comes to 100, because of that fantastic temporal resolution, you find some very pristine coronaries. So this has been a quantum jump in the technology of how to pick up difficult to image heart rates. The radiation is also another problem. You can see here that the dose of radiation without the ECG pulsing is extremely high. The order of magnitude of CT was anywhere between 12 to 16 millisieverts. When you use a single source with ECG pulsing, like I talked to you about systole and diastole, you see that a lower heart rate, the radiation is much lower compared to higher heart rate. And that's the reason why we like our physicians to beta blockade patients as much as possible using either beta blockers or calcium channel blockers to not only make sure the picture quality is good, but to ensure our patients get the lowest amount of radiation possible. The dual source technology does away with this concept. And at any given heart rate, the dose is very, very acceptable, making it a very, very good tool to do what is called screening. And this is just to reiterate the same thing. A typical spiral CT would be anywhere between 14 to 18 millisieverts. The classic cardiac 64 slice and below, we call it the step and shoot, would be anywhere between 4 to 8 millisieverts. But with the dual source technology, using the spiral and step and shoot, we have a very acceptable 3 to 5 millisieverts, which is the norm today. And today we have also moved from there to sub-millisievert doses, especially in the pediatric population. And this is the pristine images you get at very low radiation doses, almost half of what you get in a single source scanner. And you can see the plaques very clearly shown. Again, to show the concept at a high heart rate, varying heart rate, bad images, even if you do multi-segment recon, but with the dual source, you get very, very pristine images. And this is just in close-up to look at the LAD with the stent. You can see how pristine it is on a dual source. And whatever software iteration you may do, reconstruction, you get some very bad images. So cardiac CT, as I've been talking about, is excellent for anatomy. You can do the MIP images. You get the special VRT uh, coronary images. You get the whole heart VRT images. You can also look at the valve morphology, and this is the basis of why we use it for TAVR today. So cardiac CT has evolved. And the beauty of looking at a pristine coronary image with no calcium gives a very, very huge protection to a patient. We're able to look at stents. You can see in the RCA LAD, long stent, short stent, VRT also showing it. You can actually see through the stent. We do zoom ups to the stent to look at the peristent areas, and you can see this patient has a pristine stent. So it's very good for stent imaging, provided the stents are more than 3 mm in diameter, 3 or more, and they are preferably located in the proximal segments of the coronary arteries. The triple rollout is something that many of you are aware of, and basically deals with a whole thorax imaging in an acute situation when you're not clear about the diagnosis. You get to see the pulmonary trunk, you get to see the coronaries, you get to see the entire aorta, and this is a patient with an extensive dissection. So this is possible in about 6 to 8 second breath hold, and you get some very, very good pristine images, excellent in the ER. I'm going to show you some cases for the remainder of the time. And as I said, the protocols may be a little different than what you're used to, but I have used some of these to just highlight specific issues. The first case is a 58-year-old gentleman with no risk factors, came to the ER with chest pain, no ECG changes. Because of his age, he's come to the ER middle of the night. You can't just send him home. So what do you do? These are the options that are there in front of you. We don't have polling, but anyway, whether you want to do an angio in the middle of the night, stress maybe labs generally work 8 to 5, or do you want to do CT? Did a CT for this patient, absolutely pristine images, left side, right side, branches, septals, whole heart image, very beautifully showing a calcium score of 0, gives a lot of confidence to the ER physician to send him home on conservative medication, decreases hospital stay, decreases the bill of the patient. And with the current day COVID time where people are always online and good teleradiology techniques, they can be reported by a senior radiologist even sitting at home. Case number 2, 36-year-old male corporate executive. Again, ER presentation with chest pain, very strong family history. Father died at 55 years, no autopsy done, non-smoker. TMT done as a screening technique, positive for stress-inducible ischemia. What do we do next? This case, we went ahead with the CT, and this is what we found. VRT images. Look carefully at this structure. Again, this structure, this is the left side. So what you're all seeing is the left coronary sinus, the left circumflex, the LAD along the septum. But what is important is you're able to see another vessel going anteriorly. This is posterior, this is anterior, between the pulmonary artery and the aorta, winding around and supplying the anterior AV groove, which is the right coronary artery arising from the left coronary sinus. You can see the compression here of the right coronary between the aorta and the pulmonary trunk. This is the case of a malignant right coronary artery arising from the left coronary cusp. The plot gets a little thicker here, and in our fairly large series, which we have also presented, not all of them go for surgery. We have found that when we did the stress nuclear scans for these patients, only about 50% showed ischemia in the RCA, and they went ahead and got grafted to the RCA. It's important here, obviously, to tell the surgeon that he needs to clamp or ligate the RCA at the origin. Otherwise, there would be a competitive flow. Relocation of the RCA coronary ostium to the right sometimes can be challenging, and not all surgeons are comfortable doing it. The other 50%, surprisingly on beta blocker therapy, had normal stress MIBs. Most of them had attained their 10 mets without any problem. And what we did find when we looked at the data is that the patients who had a coronary artery coming from the left little lower down were actually protected because they were well ensconced in the fibrous area of the aorta. Let me just show that to you. So we're not only looking at a horizontal level, we're looking at this vertical level. So the lower the coronary artery origin is, it gets protected by the fibrous trigone which is there around the great arteries. When you're a little above, about a centimeter or 0.8 centimeters above, you then encounter muscle in the arteries, and they are the people generally who got a stress maybe which was positive. This was an incidental finding when we looked at the data. 57-year-old lady with worsening shortness of breath, atypical chest pain, hypertensive, old MI, status post PCI to LAD. Did her angiogram. You can see these images. It's an osteo total occlusion of the LAD. You can see some part of the stent there. There's absolutely no flow. What do? Do you do PCI to LAD? Look at viability on the MR? Use intravascular tools to look at the process that is going on in the stent? Or can you just manage with CT? CT was done showing the same findings as the coronary angiogram, but what it showed was a diffuse instant restenosis here in the LAD stent with neointimal proliferation and black with a complete occlusion of the LAD with thrombus across. But what was also important, and this was one of our pilot studies to look at scar imaging on CT, and that's why we just chose this case. And we found that when we use what is called a dual energy sequence, remember we've been using a dual source CT. So each source we change the kV, 120 versus 80, and the 80 kV source would look at the myocardium, and the 120 source would look at the coronaries. So you got a very beautiful binary picture of good coronaries, which you have just seen in the previous slide. But you also had a look at the myocardium, which was possibly one of the first things that we've done in this country. And you can clearly see that this is the normal myocardium in orange, and the black is the myocardium with very poor perfusion, clearly showing from the mid-segment onwards or the first diagonal, there is little or no perfusion. And what is added is there is significant thinning or thinness of the myocardium, suggesting that this patient will not benefit with the revascularization. So this was one of our first tools. And then a little earlier, we had some other authorities looking at CT as a tool for looking at volumetry, for looking at viability, and comparing it with the traditional standard, which is MRI, and clearly showing that you can use CT as a very good tool to look for scar in patients, provided you use the right protocols, and they almost mirror imaged MRI and the TTC stain. So CT had truly come a long way. We also know from Allman's data that once a patient has a non-viable myocardium, they really do not get much benefit after revascularization. This is just for the residents to sort of recapitulate. Hence, this patient was kept on optimal medical therapy. Case number 4 is a 54-year-old male with atypical chest pain. He's diabetic, no prior cardiac history. Clinical exam was within normal limits. For some reason, he got an angiogram done, showed a total occlusion. He actually went on a pilgrimage and had some atypical symptoms. The left side was completely normal. We did a CT on this patient. And what we clearly showed, and this was some of our first attempts at looking at CTO or evaluation of CTOs by coronary CT. You can see the same stump with the same branch here on CT, but you can also see a track here with a little bit of speckled calcification and the distal reformation of the vessel. And based on the Rector score, which is a CT-based CTO score, like the Japanese score which you do on the angiograms, you can get a fair idea of the success of a CTO revascularization. What is also important is that when we did the MRI for this patient, we found hypokinesia of the inferior wall and a consequent transmural scar of the same wall, suggesting that this patient will not get any benefit after a complex revascularization. And these are the MR pictures showing the transmurality of the scar in the inferior wall and inferior septum. And hence the patient was kept on optimal medical therapy. Case number 5 is a 48-year-old lady with chest pain diagnosed to have an infraposterior MI, was given thrombolysis in a peripheral center, referred here with persistent chest pain. 2D echo revealed a moderate pericardial localized effusion in the along the infraposterior wall. And based on our experience of almost 15 patients, we didn't go ahead to the cath lab. We wanted to look at what was the cause of this persistent pain and effusion. So the choices were, do you do a T and look at the rupture site? Do you do an MRI and will you be able to see the scar effusion, or will you be able to see the coronaries? Unlikely. Would you just go ahead and do an angiogram and look at the coronaries, but you're going to give heparin and we're dealing with a major problem, a possible myocardial rupture? Or would you like to do CT? So CT was done. This is the orthogonal view, the left ventricular outflow tract view, showing an amount of contrast extravasating here in the infraposterior wall. You can see the rim of pericardial effusion over here. The same thing can be seen here, that there is effusion. And here you can see the outpouching of contrast here, suggesting a myocardial rupture through the wall, a serpiginous tear. You can see the decreased rest perfusion here in black. We talked about that before, the ring of pericardial effusion. And the same picture showing you the extravasation of contrast into the myocardium. What is most important is you're able to view the coronaries. All coronaries were normal except an OM which was occluded. OM occluded. In our series of 15 patients, we found that the most common cause of myocardial rupture were the diagonals and the OMs, not the big arteries. And this is something that we have also published, the role of multi-detector CT in the evaluation of myocardial rupture. So this patient went ahead to the theater and just got a pericardial patch repair. Nothing was done for the OM because it was occluded and there was no perfusion distally to the OM. So it was just left alone and a pericardial patch surfaced and the lady actually went home on the 6th day. It's another case of a 58-year-old lady presented with chest pain on exertion, diabetic, hypertensive, angiogram done. Forgive me for these images. They were sent by somebody. So you can see, focus on the left. There was an issue of the coronary cannulation. Images were not great. Some haziness in the left main, haziness in the osteoproximal LAD. Images were not clear. Patient was very tachycardic. So this patient was referred to me from another center because the LMCA LAD area was not very clear. It was inconclusive for significant stenosis. So would I be able to sort of look at this area well, or would I recommend any other test? FFR versus IVUS, this was some time back, so these were not that freely available. Would you want to do a stress maybe on this lady to see if it was important? But the lady was sick, very tachycardic. We didn't want to disturb some kind of a plaque by stressing her. So we went ahead and did a CT. The right, as expected, was normal. Now, this is the area which is really excellent on CT, and that is the osteoproximal left main and the ostial LAD. You can clearly see significantly compromised by a calcified plaque, very nicely seen. This patient had a heart rate of about 110, very poorly tolerating beta blocker, but still we went ahead and with our dual source, we were able to see a significant plaque in the LM-LAD zone, suggesting that this was an important lesion. Also, we did find that the osteoproximal left circumflex was also involved. It was no longer a left main to LAD lesion, but there was a circ lesion with a large OM1 subtending it. And hence, based on this information, we actually send this patient for surgery. Case number 7 is a 57-year-old lady, short of breath, worsening since 1 month, ECG showing an LBBB with QRS duration of 154 milliseconds, dilated LV with significant dysynchrony. There's a plan for CRT. We know there's a 15 to 20% failure rate. So in our centers, we have been evaluating certain tools. Can we look at the T? Can we look at MRI to see the coronary venous pattern to ensure that the patient has a successful outcome and is a responder? Whether we want to be looking at scar in the infralateral wall in these patients, because when you put a pacing in the scar tissue, you don't get a sufficient response. Or you like to do a coronary angiogram. In many patients we were doing, and then we would do a balloon occlusion and then look at the coronary veins. In the coronary sinus, we should do balloon occlusion and see the coronary veins. But by the time you've already sort of prepped the patient for the procedure, the patient may have paid, usual corporate hospital problem. So we said, can we look at CT for this indication? These are CT pictures of the same, showing a dilated LV, markedly dilated, thinned wall, dilated left atrium, pulmonaries are dilated. Structural images that we're good at. What is important is when we don't give nitroglycerin, which we usually give for the coronaries, you get to see the venous system very well by a slight delay in your acquisition. So all the veins really come out well. And what is very important is we can map out the posterolateral veins, which is generally the place where you want to put your lead. And that's the area you want to excite with the left ventricular lead. And you get very, very good pictures. You get a clear anatomy of the CS. If there's any webs, if there's any kind of obstruction from the CS to the posterolateral veins, sometimes we see those things. We need to do even a balloon venous angioplasty. So this gives the whole track of the venous circuit. So much before the procedure, you know that there's going to be a high chance of procedural success. There's a high chance of being a responder. And therefore, you also minimize the radiation time for the operator and thereby lead to a successful outcome. 2 decades ago in the developed world, the myocardial perfusion scan used to sit at the top of the pyramid as a very important tool to risk stratify patients, especially as a gatekeeper before they would go to the cath lab and subsequent intervention. But after the advent of CTA, most of the preliminary work, and you can also see that it is there in the NICE guidelines UK, where the CT angio has picked up most of the screening work with the myocardial perfusion does. It does it at a fraction of the time, about 10 minutes to be exact. The myocardial perfusion scan is a whole day at the hospital. Lower cost, lower radiation, average radiation being 3 to 5 millisieverts for CT versus 10 to 15 for myocardial perfusion scan. Severe lesions go to the cath lab directly. Mild lesions are managed medically. Borderline lesions then go to myocardial perfusion scan. We have a lot of operators in Japan, Korea, and some in the US who are doing cardiac CT perfusion, stress perfusion. We have also dabbled in it for some time. Because of lack of funds and research funding, we stopped. CT is now able to do stress perfusion with adenosine. So you have a borderline lesion, you give adenosine, you run the CT again, and you can look at the myocardial perfusion, which I showed you. And a decreased perfusion basically means the lesion is important. FFR CT also is coming into this zone. We'll have it ready to go in India by the next year. and you're going to be able to know which lesion on CT can be taken up to the cath lab and which can be managed medically. So the CT is turning out to be the gatekeeper in the Western world. The Indian scenario has been a little different in that most of us would prefer to go to the cath lab at the word go and then do the intervention. Few centers, especially the metros, would then dabble in the myocardial perfusion spec for borderline lesions. We obviously now have the FFR, OCT, and the IVUS now to look at them. But CT is revolutionizing things in India as well, and it is the go-to technique now in most of the metros, big centers. Whenever there is a doubt of coronary artery disease, especially in the intermediate risk zone, CT is the preferred technique just because it is so easily available and useful. In patients with LV dysfunction, prior MI, the gatekeepers obviously are the nitrate scans, the myocardial perfusion scan with NTG augmentation, and the cardiac MRA, and obviously the PET in some centers. And only if patients have adequately viable myocardium, they go to the cath lab and gets fixed. In those patients with prior minor events with only mild LV dysfunction, they would either go to the cath lab directly, just get a stress done. If the stress is positive, they would go to the cath lab. In those patients who have a normal LV function and no prior event at all, typical intermediate risk group, CT would be the tool to do. Significant disease, cath angio, mild disease medical management, especially statin. This is also a place where aspirin would have a role in primary prevention when you have a significant plaque burden, generally defined as more than 330 on the calcium score, and borderline stenosis will get the myocardial perfusion scan. In short, ladies and gentlemen, CT is non-invasive, it is safe, there's a very short scan time, excellent spatial resolution. However, it does come with some problems. There's a paucity of data, randomized controlled trials, radiation is still omnipresent. We've cut down radiation from 15, 16 millisieverts to about 5 millisieverts to an average, but we have a way to go. Iodinated contrast obviously is used in these patients, and any patient with severe LV dysfunction or renal issues cannot have the scan. What is important is that the imaging suite works very well with the rest of the cardiology services. The emergency room should be connected. There has to be a lot of support from the referring physicians for the program to grow. You need to have a good tech, in fact, a number of techs to make sure your night service is well staffed, and obviously very good nurses to put in good IVs, do breathing techniques for the patients, and run the scanner. So we are about a decade old now, a little more than a decade, having done about 15,000 cardiac CTs. So hoping to continue the good work. Thank you, everybody. Over to you, Mohit.
Yeah, thank you, Johan, for a very nice lecture, elaborate lecture. It looks like you have presented even new aspects of CT scan, which generally like imaging and viability. We never even knew that it could image scar so beautifully with the dye, and it was very nice to see. So, what is otherwise your experience about the anomalous coronary arteries, and what are the major limitations with the current evolved technologies that you see that CT has? That we face that often it is very difficult to evaluate the patients who had stenting done, but you showed very good and emphatic images. So what do you see are the real challenges for CT imaging in the coronaries?
So we've come a long way, as I said, over a decade. A decade ago, if you'd asked me, there have been a lot of holes in my story about what we can and what we can't do. But right now, we are very well poised, I think, to answer most of the clinical questions thrown at us by the average cardiology problems that come in, especially the emergency kind. We talked about rupture, we talked about in-stent restenosis, stent thrombosis. But I think all of it depends on a very close working of the imager and the rest of the cardiology group. Basically, they feed each other. We give you good images, provided you give us a good story. You sit with us after the scan and then make sure the clinical and all the other things are integrated into the story. You saw the cardiac rupture case, which would have otherwise gone to the cath lab, got heparin, and patient would have collapsed. We had those cases as well. So I think just the integration of the technology. So I don't believe CT is any great technique. I believe it is the integration of the technique with the cardiology workflow, which is truly elevated it to a fairly robust and a very, very good tool of today. So when you don't have that integration wherever you are, you're going to get bad images, you're going to get lousy pictures, you're going to get completely different answers than what you were expecting. I will just tell you a case I just got yesterday from a fairly senior interventional cardiologist. Patient with heart failure came to him, was referred as heart failure, saw the patient, did the workup. He thought it was constrictive pericarditis. There was a little bit of thickening of pericardium. There was pericardial effusion. He almost went to the cath lab and someone just suggested that you've done the MRI. The MRI said it was constriction. So he said, why don't you just send the images through Johan and have a second opinion before you take to the cath lab. And about 8 minutes later, when it came through my V transfer, I saw it. I said, you're dealing with the cardiac amyloidosis, send them to the hematologist. So I think it's very important to be comfortable with those images. It's very important to integrate everything with the story. And the same MRI saying it's constrictive pericarditis and I saying it was amyloidosis. And then we did the T1 mapping to resolve the conflict. We talked about it last time and you were also asking a few questions. The T1s were markedly elevated across the myocardium, which I said was, I would almost say, an exclusive feature of cardiac amyloidosis, unless we pick up some other disease which looks like it. So it was very heartening that, and now, of course, as I said earlier, we have good agents for cardiac amyloidosis, so we could give a new lease of life to this patient. Otherwise, this patient may have well gone under the surgeon's knife. So I think images are not enough. We are moving away from pretty images to very integrated imaging data sets where people sit together, do the job. And also, we are moving from pretty pictures to what is called parametric imaging. I talked about the T1 mapping, the T2 mapping, cardiac CT. We also look at the Hounsfield units, the calcium scores. So a lot of the things have become very quantitative. We quantitate the ventricles. Patients with query ARVD who already get a pacemaker for various other reasons. We do CT, we quantify the right ventricle, and we prove that there is a amount of fat deposition. We prove that there is scarring in the RV free wall. We're able to do the RV volumetry almost as good as the MRI. So I think we are reaching places where we possibly never expected to go. But all this can happen only if you're working in a very controlled environment where everybody is sort of pitching in, and you're able to do that in an integrated fashion. Left alone, these imaging tools would be of really hardly any use. And I know many cardiologists swear that they would never get a CT done for their patients based on their past experiences. So we've had those things also. And for Dr. Sumit, if I got his name right, the best places for cardiac CT is pediatric cardiology. It's just amazing that 4 or 5 kilo infant or neonate, we image them in about 4 seconds with just what is called monitored anesthesia. And the patient is sent back to the ward compared to what you would have to do in the cath lab, hypothermia, venous access. It is a nightmare even for very good operators. So we get the left, right, the pulmonaries, the PVs, and all those little things which I know Sumit would like to get in about a 5-second time. It's a very beautiful thing. And actually now the surgeons prefer us rather than the pediatric cardiologists.
Any questions, Dr. Sumod, Dr. Girish?
One common reason they send back patients when we refer for CT angio, patients' heart rate is irregular, breath hold, not sufficient breath hold. Any way to, the newer technologies has anything to help us with these issues?
Yes, again, these were issues definitely. But I have been working with a 64 slice for some time before I moved on to a dual source. And I can tell you that technology helps only to a certain extent. A good nurse, a good technician, good beta blocker, allaying the patient's anxiety, making sure they don't have caffeine on that day, prior treatment with beta blocker. We've got Iverbrad, which is a great molecule for our lab. We didn't have it 10 years ago. So we have limited these so-called artifacts. In fact, a lot of my patients come who have been rejected by other CT labs just for high heart rates. So with good use of pharmacology, good use of technique, good use of a well-trained support staff, the nurses and techs, you can get by through most of these problems. You will still have about 4 or 5 patients who just cannot be evaluated, but that's a very small minority when you look at the general odd number of patients, 10 to 12 patients we do per day. So maybe 1 in 3 days or 4 days, you end up with images which cannot be really evaluated. But I think more than the technology is definitely getting there. So the current breath hold is about 4 seconds, which is fairly easy to do. We have whole heart scanners like the 320 scanners, where in one heartbeat, you get the whole data set. You don't need to look at multiple heartbeats. So arrhythmia is not an issue at all. You just need one RR interval and you've got the whole data set, which is very good for pediatric cardiology. So technology definitely has made its presence and has eliminated all those little problems which we have been seeing. Stents especially has been a real breakthrough. We've got good iterative software, and we have the new G scanner. A couple of my friends have started using it, wherein you can actually subtract the calcium based on their patented technology. So if you have an artery which is just loaded with calcium and you think there are some significant lesions, and I know many of these cases go to the cath lab and my colleagues laugh at me and say, Johan, it's just mild. And for me, the whole vessel was covered by adventitial calcium and I'm made to look very small. But the new G750 series comes with a calcium extraction software using the hydroxyapatite technology. And you can actually strip the calcium off these arteries and actually see through the real lumen, which in many times is actually quite okay. So yes, technology has come a good way. The higher end scanners are equipped to deal with about 85 to 90% of what we were rejected before. But nothing like a good operator, and more than a good operator, a very well-trained team.
In general, when we advise CT angio, we generally say to patients that very high, negative predictive value, we can 100% rule out. But positive predictive value, we are little, we are not. How has the, I think with all the, ability to say the plaque morphology and all, how far we have come with the positive predictive value? We can really be sure about the stenosis severity with the improved technologies to quantify the plaque and all.
CT always will be, it will always never be a competitor for the coronary angiogram. It is primarily a screening tool for the intermediate risk group, and that is where it's supposed to be used. It always will have an extremely high negative predictive value, 99%. The positive predictive value has always been the Achilles heel, will also continue to be despite whatever technology comes in. So it is very important to choose which patient goes there. It's very important, however good your CT is, to get the heart rate down, calcium channel, beta blocker, ivermectin. It's very important when you have a patient who's well trained for breath holding, because breath holding creates major problems in evaluation. High heart rates give a lot of problem in evaluation. Calcium is the biggest enemy for CT. So heavily calcified arteries, when I see them on the calcium score before I give contrast, especially if I find the patient more high risk than intermediate risk, or if I find the patient has fairly typical angina, I stop there. I give a call to my colleague in the outpatient and say, this patient does not belong here, got heavily calcified arteries, calcium score is about 1,000. He needs to the cath lab. He needs to go to the cath lab straight away. So I think at the human level, a lot of what we do gives a very good positive predictive value. The Achilles heel is always there. For that reason, the two new emerging technologies this decade has been CT perfusion with adenosine. We have dabbled in it for a little while, but the Japanese have the best data. Better than the conventional FFR, but it looks at CFR, which was actually the domain of the PET scan. So while FFR looks at epicardial arteries, CFR looks at the myocardial perfusion, and CT is able to go to the CFR levels. The second area that we have really come up in this decade is the CT FFR, and we're going to see that on the terminals from next year. We have been sending all our FFRs to a place in Redwood, California. That's the only place that does it, called HeartFlow Technologies. In fact, it has a patent and it is well sort of serviced by many of the top American interventional cardiologists. So that's the reason the technology possibly has never gone to the rest of the world. So that is going to change from next year. I think the patent is going to go off. The CT-FFR is going to be a great tool wherein some of these borderline lesions, radiologists not able to look at properly, quantification of problem, all are going to go away with the FFR. The FFR is going to be a very robust, like it is there in the cath lab. It's going to be a very robust tool. It's going to add another 20 minutes to your evaluation. It adds no radiation to the original CT. It adds no extra contrast. But in about half an hour, you get a CT FFR and you know exactly which lesion to tackle as an interventionist, which to leave alone, which to keep on medical therapy. So right now, the turnaround time is about 24 to 48 hours. It's $50,000 right now, but all that is going to change hopefully from 2022.
In pediatric cardiology, many times the challenge, picking up some VSTs and subaortic membranes and some LV to aorta tunnels. Generally CT, probably because of the spatial resolution related issues, I think MRI may be a little more better in picking up those details, because many times the surgeons say you have reported in this, and CT it is not there, and we have to show them on echo that it's there really. Membranes and small VSTs and.
So again, most of it has to do with the clinical question that was asked. If you do not tell the imager what you want to see, then he's not going to time the contrast. Unlike MRI, which has its own contrast, that is, the myocardium has its own inherent contrast to play with, CT is completely dependent on iodinated contrast. So if you're not going to give the whole story, what to expect for the child, you're going to give the contrast some other way. You're going to give it through the left subclavian, for example, when you're looking at an IVC interruption, for example, when the clinical question is IVC interruption, you're going to have a vascular link query on the left on echo, but you didn't give this information. He's going to give the contrast on the left, and that's going to completely cast a shadow on the vascular ring. So the CT is completely dependent on your clinical question, your clinical story, and what exactly you want in addition to the very good data that most of us get on the echo. And I'm sure most pediatric cardiologists have been managing about 80% of the practice with their very good quality echo. So the CT will only answer that it has been asked. You cannot send a patient for a CT and expect all these lesions to come out. It will never, because it's completely based on the route the contrast takes and the timing of the contrast. So unless you're going to be sitting with the tech or sitting with the imager, you're going to get a lot of these problems. MR that way is a little more independent because it uses its own contrast. And again, if you don't image the right way in MR, you're going to miss things. So both these tools are, I would say, complementary. They're not a replacement for the traditional echo or the angiogram for that matter. These are all, as I said in the last meeting, multiple data points in this big jigsaw puzzle we call as coronary disease or congenital heart disease. So one of these jigsaw puzzles are the CT and the MRI, cannot be seen in isolation. They have to be wedged into that jigsaw, and then only they make sense. So I think the person behind this is very important. So don't ever expect even the best machines to give you good answers.
I just have two comments to make. One is, I think this CT angio would be, the advantages in the triple rule out, like coronary artery disease, pulmonary embolism, as well as dissections, compared to a conventional one, especially in emergency settings. And the second advantage, which I feel of CT angio, is definitely yes, abnormal origins of coronary arteries and their course, which abnormal origin you might pick up by coronary angio, but course you might not be able to tell what exactly is the precise course of this artery once it arises from a different area altogether. And one of the biggest takeaway for me, there is a notion in general public as well as the doctors at large that compared to your stress thallium, your CT angio has more radiation. Contrary to that, you have very clearly said that, and it is beyond doubt now that CT angio has the newer generation especially have less radiation compared to stress thallium.
Yes, sir, absolutely, absolutely correct. In fact, the indications you talked about are the perfect indications for doing CT. And these are the indications we also would really work with. I just presented some esoteric things to just show you the length and breadth of CT. These are obviously not things that I would do for a living.
So I think it was a very practical talk today. Maybe because this is one of the modalities which we all are going to use in our practice. But most beautiful thing is that you have shown how beautifully it is extending, its use has been extended, how it is aiding the intervention cardiologist, how is it also telling us where not to intervene. Because very commonly it happens that patients are having mild or moderate pericardial effusion, and you said that CT scan is revealing you a rupture, and which is quite often missed. You are able to, some people are intervening in that, and sometimes you lose the patient after that. So CT scan, if used judiciously and very importantly in integration with the cardiologist, both the team, like a heart lung team, like a CTVS and so cardiologist team, similarly a radiologist cardiologist, when they are working in harmony with each other, probably you can make the best use of these technology. So thank you, Dr. Johan, for nicely bringing us the practical aspect, especially in the coronary artery disease, the role of CT angiography. And we look forward excitingly to your next talk on nuclear imaging, because nuclear imaging is one of the jigsaws of cardiology, which most of the doctors, consultants, and even the senior doctors are confused at which modality to choose, when to choose, and what should be the recommendation, and how should one approach it. So I think probably we'll be disturbing you again, requesting you again to speak on this particular topic in detail, giving us a very practical aspect, and showing us some beautiful images and questions that we are able to deal, and our residents, our fellows are able to answer all these questions, deal with these jigsaw puzzles in the exam. So thank you for a great lecture. In case you have missed the previous lecture on magnetic resonance imaging, I would request you, I've already posted in the groups. You can visit our channel PG Track CSIDB and subscribe to the channel and download the talk, listen to the talk, see the moving images, interpret, and also go through the quizzes that Dr. Johan has predicted last year time. This talk will be uploaded within a couple of days, and we'll catch up next time on Thursday, same 6 p.m. with the third and the final session in the imaging in heart disease that will be specifically focusing on the nuclear imaging. Thank you, Intas, for providing us a great platform. Thank you to my colleagues, Dr. Sumod, Dr. Girish, and thank you once again for taking out time after a busy schedule. Thank you. Look forward to it.
Thank you very much, Mohit, and the rest of the faculty.
Thank you, and thank you.
Thank you, Joe.